morning everyone. Myself Dr. Jayesh Prajapati, Professor and HOD Cardiology, UN Mehta Institute of Cardiology. In this academic program, today I am going to discuss on the echocardiographic assessment of right ventricle, right atrium and pulmonary arterial hypertension in adults. And this topic is important that we have given importance to the left ventricle, but RV assessment and pH assessment is also important in our practice. And this is the history regarding the right ventricle. So sometimes people consider that right ventricle is one of the ignored ventricle, but there are in hemodynamics this is also important ventricle like left ventricle. So in 1616 William Harvey was the first to describe the importance of RV function in his seminal treatment Anatomicus de Motu Cordis. So RV is made out of the it transmit the blood to the lungs after collecting it from the veins or the periphery. And of course we have to know the hemodynamics, and this is important. Why? Because we know that the pulmonary embolism, infraval MI, associated RV MI, and sometimes we have seen that in acute MI the ejection fraction with RV infraval MI is around 45-50. Still the patient is in a hypotension. So that's why the RV is very important for assessment. And another thing, rheumatic heart disease and congenital heart disease, whenever there is Eisenmenger or the severe PH kind of situation, RV is important to assess. So we should know the anatomy of the RV. RV is little bit different compared to the LV, and it is most anteriorly. When we see a lateral X-ray, it is an anteriorly situated cardiac chamber and inferior border of the cardiac cellhouse is mink. It is triangular in shape when viewed from the front and crescent shaped when viewed from the apex. And there is a crossover relationship between RV and LV outflow, little bit crossover, it is not parallel. And pulmonary valve marks the superior margin of the RV, while the tricuspid valve marks its right margin. And apex of the RV is frequently inferior to the left. So apex is made up of the left ventricle, as we have studied in our clinical cardiology. So crux of the heart, crux cordis, refers to the intersection between the two planes. So how we can differentiate RV and LV? So RV is most anteriorly situated chamber. Coarse, it is when we see the echocardiography, it is more coarse compared to the left ventricle. So coarse apical trabeculation, and there is a moderator band, which one of the identity of the RV. Variability in number of papillary muscle are variable because of tricuspid valve and leaflet are little bit size is different, and there is a lack of continuity between inlet and outlet. So like that aortomitral continuity, same thing is not that tricuspid and pulmonary continuity. So conus is one of the important thing, and tricuspid valve septal leaflet is more apically situated. When we see the fourth chamber, how we can, usually the valve goes with a ventricle. So apically displace that leaflet is tricuspid. So tricuspid valve septal leaflet is more apically situated, while the LV is a posteriorly situated ventricle, and there are fine apical trabeculation. There is no band like moderator, fixed number and arrangement of the papillary muscle, and there is, as I was told, the aortomitral continuity is present. So this is how it looks like. So there is a tricuspid valve followed by inflow tract, and there is a apex, and there is a infundibular, and there is a membranous septum is there. So this is the inlet. Inlet is the portion containing the tricuspid valve. The three leaflet are the septal leaflet, which is more characteristic, and what we see on echocardiography, multiple tendinous cord attached directly to the ventricular septum, and another leaflet, anterosuperior leaflet, that is one of the largest and most mobile and deeper than the septal leaflet, forms the intracavitary curtain that partially separates the inflow and outflow tract, and supported in its mid portion by a large papillary muscle that usually arises from the moderator band close to its insertion to the parietal wall. And what is inferior leaflet? That is Inferior leaflet is the posterior leaflet and usually the smallest, supported by the several small papillary muscle which arise from the diaphragmatic wall of the RV. And this is the infundibulum. And infundibulum is formed by the VIF and anterosuperior wall of the RV. It forms the supraventricular crest at its septal margin, and infundibulum leaves the pulmonary wall clear of the ventricular septum and free of muscular trabeculation. So infundibulum, that what we see in pulmonary stenosis, and sometimes when we see dilated, so infundibulum is also one of the important part of this structure. So arrangement of the trabecular. So there are multiple trabeculation in RV, and there is a Y-shaped strap that embraces the ventricular infundibular fold between the arms. So we see multiple chambers or multiple trabeculars, and sometimes one abnormal that we have to keep in mind is a DCRV, double chamber right ventricle. When abnormally formed hypertrophied, it can be a substrate for dividing the ventricular cavity into two chambers. Sometimes we see the mid cavity gradient in DCRV, or we see the gazulization. Gazulization means we see infundibular gradient which have got a VSD, and because of flow sometimes the hypertrophy occurred and pulmonary wall is normal. So gazulization, DCRV, that are some of the anatomical variant in case of RV hypertrophy. And moderator band is a physiological structure takes from the body of the Y to cross the parietal wall. And how physiology, how the RV contracts. So RV doesn't contract like this. This is like a daman. So RV contracts by three separate mechanisms. Inward movement of the free wall, which produces the below effect like this. Why? In contracts of longitudinal fibers, we shorten the long axis and dodge the tricuspid towards the apex like this and like this, and traction on the free wall at the point of attachment secondary to LV contraction. So its contraction is little bit different compared to LV, and shorten the RV is greater longitudinally than radially. So RV contracts more like this rather than like this. So it contrasts to the LV. Twisting and rotational movement do not contribute significantly to the RV contraction. So it is a little bit like peristaltic movement. So RV is a unique physiologically, largely dependent upon the flow, upon the low hydraulic impedance characteristic of the pulmonary vascular bed, because pulmonary vascular bed is a low pressure bed and RV is working in a low pressure area. So how RV output approximately that is the same, because the same blood passes the LV, same blood to the RV also, but it is achieved with a low myocardial energy and 1/5 of the cost because of two reasons. It is a low pressure chamber and unique characteristic of the RV pressure volume relationship, and it is mostly like it contracts like peristaltic motion, and contraction of the infundibular is of longer duration than the contraction of the inflow portion. So infundibular like this peristaltic movement. So infundibulum is a longer duration compared to the inflow portion. So these are some of the discussion points that already I will discuss, that we are giving more importance to left, but right is the same important chamber. So what now I am going to discuss? Now I am going to discuss the RV size, RA size, RV function and pulmonary artery pressure. So these are the basic view that what we do: parasternal long axis view, parasternal short axis view, and of course pulmonary artery, how we can assess, RVOT how we can assess, and see the LV. Whenever we see the short axis view, parasternal, we see that LV is a globule, we see the round. So septum is a part of the LV cavity. So that is what we see in our usual view, and we little bit tilt the parasternal long axis view. We can see the better of the papillary muscle, coda tendini, everything RV part, and we can see the infundibulum also. See little bit tilting, short axis, long axis view, parasternal view, we can see such kind of chamber. And these are the basic views: 4 chamber view, RV oriented view, we can see the moderator band very easily, we can see the RV orientation, we can see the coronary sinus also, we can see the pulmonary veins draining into the LA, and we have to see the subcostal view. That is also important. Subcostal view gives the inferior IVC opening, and of course the sinus stenosis ASD kind of thing. ASD also we can assess subcostal view, and these are some of the basic views. Little bit tilting, we can see the LA, RA, infundibulum, RV cavity and everything. This is some of the segmental nomenclature of the RV valve with its blood supply. So majority of the RV is supplied by the right RCA, right coronary artery, and some part may be from the circumflex. If the circumflex is dominant, then the things are different, because the dominant circumflex then supply most of the part of the RV cavity, and septum is the majority supplied by the LAD, and some of the part is supplied by the coronal branch. So these are the blood supply of the RV that we have to keep in mind while doing the echocardiography. And how we can measure the right heart dimension. So right heart dimension is a focused RV 4-chamber view, where we can see that some of the angulation we can focus on the RV. Another, we have to measure the RV wall thickness in a subcostal view, and it is measured that less than 0.5 centimeter or the 5 mm is the normal, and we have to see at the peak of the RV, peak of the R wave, that we have to measure the RV wall thickness. So as I have mentioned, and it is, we have to see the ECG and thickness of the RV more than 5, then we can see that there we have to think that patient has got a RV hypertrophy, or there is a PAH, or RV pressure overload is there, and it should be measured at the level of tricuspid valve, chorda tendini, and at the peak of R wave in the subcostal view we have to measure. And RV dimension, we have to measure diameter above the tricuspid valve annulus, mid RV cavity, and we have to measure the distance from the tricuspid valve annulus to the apex. So these are the 3 measurements. At the annulus, mid RV cavity, and the length we have to measure RV dimension, and accordingly we can say the normal or abnormal, mild, moderate, severe abnormal, as I have mentioned in this slide, and these are the length, mid RV and major RV diameter. Another thing we have to measure is the RVOT diameter just below the tricuspid, below the pulmonary valve, and of course, and then the RVOT and RVOT1 and RVOT2. RVOT2 just below pulmonary valve, and another is at the aortic level, and we have to measure the pulmonary artery diameter, RPA and LPA both, and accordingly these are the dimension: mildly abnormal, moderately abnormal, severely abnormal at the RVOT1, RVOT2 and pulmonary artery diameter. Accordingly, we can say that more than 30 PA, then we can say severely dilated pulmonary artery, moderate 2.6 to 2.9, normal is 1.5 to 2.1, and 2.2 to 2.5 is mildly abnormal. Another, we have to, as I mentioned, whenever there is a RV, important another thing, we have to compare with the LV. Usually the RV is smaller than the LV, so it is 2/3 of the LV. Whenever it is either equal to RV, equal to LV, or more than LV, that is also one of the assessment, crude assessment. So RV dilatation mild is 60 to 100% of the LV, usually is less than 60-75%. It is more than 60 to 100% is mild, moderate equal to the LV area, severe exceed the LV area. This is how we can say that RV is dilated. Whenever RV is severely dilated, we have to see that systolic flow reversal in hepatic vein and vena contracta with more than 0.7 mm, regurgitant jet area more than 30% of the RA, annulus more than 4 cm with inadequate RV with tricuspid coaptation, when the tricuspid are not closing at all. This is very severe TR. Late systolic concave configuration with increased tricuspid diastolic velocity more than 1.5 and regurgitant volume more than 45 ml. So this is severely RV dilatation. See, it is more than RV, more than LV cavity, non-coapting tricuspid valve, severe TR. So this is severely dilated RV cavity. Another important, how we have to measure the RV ejection fraction. When we see the LV ejection fraction, given more importance when we see the heart failure, like mid-range ejection fraction, normal ejection fraction, reduced ejection fraction. So LV like that 40, 40 to 50, more than 50. But RV, we are cut off is around 40. We can say RV dysfunction present or not. It's not like 10%, 20%, 40%, 45%. So RV EF is highly dependent on loading situation. RVF is under normal condition lower than the LV ejection fraction. So 40 and 75% dependence is considered to be normal. And less than that 40% is considered as a RV dysfunction. So RV dysfunction based is the MRI or the radionuclide angiography is based to assess. Echocardiography, there are some of the methods where we can assess the RV dysfunction or the RV is normal or not. So echocardiography is less accurate than the MRI or the as I have mentioned that scintigraphy or as I mentioned radionuclide angiography. But there are 3D echocardiography assessment are nowadays possible that can also give a better idea for the RV function. And how we can assess the RV systolic function. So RV systolic function we can assess by the Simpson formula also, fractional area change, tricuspid TAPSE, and another is the S- wave on the pulse Doppler velocity. Another is the RV myocardial performance imaging. So fractional area change is the end diastolic area minus end systolic area divided by end diastolic area into 100. So RV FAC correlates well with the RV ejection fraction by the MRI. So this is one of the important thing. This is how we can assess end diastolic, end systolic area and the formula, and this is how the formula can calculate the ejection fraction as I have mentioned. So RV diastolic area also gives some idea that mild abnormal, severe abnormal, more than 38 and diastolic and systolic more than 23, RV FAC less than 70% is the severe, while 25 to 31 is moderately 18 to 24. So this is how we can measure the EF also. Another is the TAPSE, tricuspid annulus motion. So RV contracts like this. So we have to see how this excursion. So this is give the one rough idea. So TAPSE 1.5 to 2 is normal, value less than 1.5 is considered abnormal, and it's also well correlated RV ejection fraction, very easy to measure, reproducible and strong predictor of prognosis with CHF. So this is how the heart RV moves. So how TAPSE we can measure. We have to put the cursor at the tricuspid level, annular level, lateral wall of the RV cavity, M mode, and this is how we can measure the TAPSE, the distance between the two lines that we measure, that is the TAPSE. Like this is a very easy method. See, here the TAPSE measure is a 19.6. It is to be considered to be normal. So this is tricuspid. This is how we can measure TAPSE. So M mode at the tricuspid level, annular level, lateral wall, and TAPSE 2 cm is normal, less 15 is 40%, less than 10 is 30%, less than 5 is 20%. So this is one of the method we can assess the RV function. Another tissue Doppler, same level, you put a tissue Doppler and measure the S- velocity, and this is apical 4-chamber view, pulse Doppler to be put, and if normal is more than 10, and this is very easy method, advanced, simple, reproducible, pulse Doppler available in all modern machine, may be obtained and analyzed offline also, but is a less reproducible, angle dependent, limited normative data in all ranges, but can give a rough idea for the RV assessment. Another RV MPI. So RV myocardial performance index, this is also one of the important thing, and normal value is 0.28 plus minus 0.04. Usually increase the presence of LV systolic or the diastolic dysfunction, and of course it is described as pseudo-normalis value in acute and severe RV MI, which can probably be explained by decreasing isovolumic contraction time. SO with an acute increase the RV diastolic time dependent manner. So here we have to measure ejection time. So this is how we can measure. So we have to see the isovolumetric relaxation time, isovolumetric contraction time, and the ejection time by the Doppler. So inflow pulse wave Doppler we have to measure, and this is the formula. This is the how we can measure in a Doppler, tissue Doppler, and this is how the ejection time and the relaxation time, and this is how we can measure the MPI, and this can also give idea. So this is approach is feasible in large majority subject. MPI is reproducible, and it avoids the geometrical assumption, and pulse TDI is available in all of the formats, It is sometimes unreliable in patient during different RR interval in particular AF patient, and whenever the RA pressure is elevated, it is sometimes misdiagnosed. RV diastolic dysfunction, same like LV diastolic dysfunction, or we say relaxation problem. So this is also 4-chamber view. We have to measure at the tricuspid level, and we have to measure the 5 beats and E wave, A wave, EA ratio, IVRT, E-A ratio. This is how we can measure the diastolic dysfunction or the diastolic function. E to E upon A ratio less than 0.8 suggests impaired relaxation. E to A ratio 0.8 to 2.1 with E to EDS ratio more than 6 or diastolic prominence in the hepatic vein suggests pseudo-normal. See, like that E is very high, A is small like LV, same thing applies here also. Then comes the RA assessment. RA we have to measure by the size. So we have to measure the normal RA area is less than 18 centimeter. So apical 4-chamber, we have to estimate at the mid-septum level, we have to see the dimension, and we have to measure the RV including the tricuspid, septum and all. We can measure the RA area. Then we have to measure the RA pressure assessment. When we see the right ventricular systolic pressure, we assume most of the cases we had 10, but it should be dependent on the some criteria. So RA pressure determined should be done on the IVC. So measure of the IVC should be obtained at the end of expiration and just proximal to the junction of the hepatic veins, that the approximately 0.5 to 3 centimeter proximal to ostium of the RV. To actually assess the IVC collapse, the change in diameter of IVC with sniff also with quiet respiration should be measured, ensuring that the change in diameter does not reflect the translation of IVC into another plane. So hemodynamic assessment, how we do? So at the TR jet, we put a continuous Doppler and we see the RVSP is a 4V square plus RA pressure. So suppose the measurement comes 26, we add a 10, then 36. So we assume that. But how we should add? That is, we have to see at the JVP or we have to see the IVC. If the IVC contracts more than 50% on inspiration, add 5 to 10. If less than 50%, add 10 to 15. If there is no contraction, then the RA pressure is high, add 20. So TR velocity you have to measure and we have to add the RA pressure like this formula. So this is how we measure. So we take a tricuspid TR jet, we make a continuous Doppler and we measure this. Suppose here measurement is 50 and RA IVC contracts less than 15%, then we have to add 15. So 50 plus 15 is 65. That is the right ventricular systolic pressure. So this is how we measure the RVSP. So that is how the IVC collapse and that is how we see it. And how RA pressure we can judge another way. So inferior IVC is dilated versus normal. Sleep plethysmography, and I have told that respiratory collapse, IVC collapse, that is one of the important thing. PA systolic pressure, this is mean pressure. Normal is 18 to 25. PA systolic pressure, normal is 18 to 25, 30 to 40 is mild, moderate is 40 to 70, more than 75 is severe. Pulmonary regurgitation, that is also whenever sometime we are not able to see the TR jet and patient seems to be severe, particularly in cases of Eisenmenger with a normal RV, not much TR, but there is a PR. So PR gives idea that pH is there or not. So PR is also assessment is most important, and it occurs in the post-operative complication of patient having a suppose top operated. We have to assess the PR also, RVOT dilated or not, because they do RV resection. So RV is also important chamber. Sometimes see pulmonary stenosis. We another HOCM patient. So RV hypertrophy and regurgitation is most important. So PR occurs rarely in congenital anatomy and sometimes progress with RV dilatation. So we have to measure the PR jet and we have to see the pressure half time. Sometimes we are not seeing any PR and we have to see pH. We have to see the pulse Doppler at the pulmonary valve. It is normally more than 120 millisecond pressure half time. Mild is more than 100 but less than 120. Less than 100 is pH is present. So this is very important thing and this is how we measure. So pulmonary, this is the PR jet and we take a PR Doppler and the lowest end diastolic pressure that we have to measure, and that gives a rough idea of PADP, PA diastolic pressure. So this is how. Another thing is that we can measure the PA, mean PA pressure also. So whenever it is helpful to use the several method to calculate. So PA, this is how mean PA pressure. So PA systolic pressure plus 2/3 of the PADP, and that gives the idea of the mean PA pressure. So this is one of the, we can see the systolic pressure by the RVSP, diastolic pressure by the PRZ, and mean PA pressure by applying both this formula. So this is how mean PA pressure we can calculate. So at the end, proximal early PR velocity plus estimated RA pressure, and this is how we can measure the mean PA pressure. So mean PA pressure is also important, and more than 40 consider significant PAH. Another thing is the pressure half time. So this is whenever you are not seeing any TR, you are not seeing any PR, then take a pulse Doppler pulmonary valve. You have to measure the pulmonary pressure half time. So this is how we have to push the Doppler start of the that PA waveform. It is more than 120 millisecond normal, and there is a notch. So another important is the notch. So RV in pulmonary hypertension, ACT is shortened to 40 millisecond, and there is also late systolic notch, which also indicates late systolic notch. So that is also important for pH assessment. Another M mode is also important in pulmonary artery hypertension. Loss of pulmonary valve A wave, downward pointing arrow in mid systolic and the mid systolic notch. So that suggests of pulmonary hypertension, and pulmonary stenosis, that is reverse. So this is how the M mode of the pulmonary valve is also important. Which are the other recommendation? PVR also we can calculate by formula. PVR can be estimated using a ratio of the peak TR velocity to the RVOT VTI. So this is the same like PVR can also be calculated by echocardiography. This is how we can pulmonary vascular resistance, TR velocity, RVOT VTI, and we can calculate the PVR. Significant PAH is more than 3 Woods unit. So this is also give rough idea whether but of course the gold standard is the cath angiography, and cath oxy is the gold standard to assessment of the PVR. Another is the RV dP upon dt. So that is also we can calculate the rate of pressure rise in the RV. So we have to put a cursor at the tricuspid TR level. We have to see that velocity from 1 mm to 2. So velocity of 1 meter square second to 2 meters square, the time taken by 2, and increase in the velocity or Hg, that's also provide rough idea of the RV dP upon dt. This is how we can measure like that at the 1 and 2 millisecond interval. This is how we can measure the RV dP upon dt. So RV dP upon dt, that is also we can measure. Pulmonary vascular resistance, and as I have told, we can measure. Another is this is like a global longitudinal strain. Same, that early systolic dysfunction. Nowadays people are giving the global GLS, longitudinal strain, for the LV assessment, and that's the early precursor of the LV dysfunction. So even while nowadays, before giving the chemotherapy, people are doing the global longitudinal strain. So that is very early marker of dysfunction. The same thing, we can measure the GLS of the RV also. So global longitudinal strain of the RV can also be assessed. So RV strain and strain rate analysis can also be assessed, and that can give a rough idea for the RV myocardial dysfunction. So that is also one thing that we can do. So why it is important? Sometimes in case of pulmonary embolism, that is important. So conditions of acute pulmonary embolism causes increase the RV size. One thing while assessing the RV, pulmonary embolism, RV acutely dilates. So acute pulmonary embolism increases the RV size prior to the augmentation of PA pressure, and quantitative assessment of guide is more towards quality of life and is functionally important. So for the pulmonary embolism, RV assessment is very crucial. And another important simple criteria, very good echocardiographer, only seeing the septum, he can say that what is the things going on. So visual assessment of the ventricular septal curvature, looking for a D-shaped pattern in systole and diastole, should be used to help in diagnose RV volume and pressure overload. So usually septum is a part of LV cavity, so there is a round shaped, but whenever it's a D-shaped, then there is a pressure overload and volume overload. So it's such kind of situation we have to think that patient might have got a pulmonary embolism or the acutely dilated LV. So we have to see that what time it persists. So end systole, mid systole, end diastole or throughout. So RV volume overload, septal shift occurs predominantly mid to late diastole. So RV volume overload is a late diastole is volume overload, while the pressure overload, septal shift is throughout the cardiac cycle with most back distortion of the LV at end systole. So this is how the septum gives idea for the RV volume overload or the pressure overload. So deseparated cavity, that is important. So to conclude today's discussion, so assessment of RV size and function is little difficult but important in of course today our day-to-day practice in case of pulmonary embolism, IHD, core pulmonale, inferior LMI with RVMI, rheumatic heart disease, Eisenmenger, post-operative patient like tetralogy of Fallot and all such kind of PPH, all such kind of patient. Normal reference diameter of the basal RV less than 40 mm, RVOT proximal 33 mm, distal 27, TAPSE, tissue Doppler, MPI, everything is important. Measurement of the PA pressure by means of TR jet, by means of PR jet, by the pulse Doppler pulmonary wall level, of course very important, along with the RV size and assessment. RA function assessment is also important. We have to see that IVC is given a rough crude idea for the volume status of the patient, and of course the RV wall thickness, that also should be assessed. Thank you so much.